Hello, ladies and gentlemen. Welcome to Triple N Media. I am Dr. Nik Nikam, a cardiologist from Houston, Texas. We welcome you to cardiology seminars on our YouTube channel. We have more than 300 lectures pertaining to the cardiology, all the way from basic science to the latest guidelines for heart failure, which was published in 2022. So we encourage you to watch these presentations, which will enormously help you to get some knowledge about passing your internal medicine boards, nursing board, or even cardiology board examinations. At the end of this presentation, I'm going to explain to you how you can get a free copy of this cardiology rotations manual with more than 250 pages of useful information that has been gathered over the last 4 decades that will be quite applicable when you are seeing patients either in the hospital or in the clinic setup. So let us begin with the feature presentation, and that is the EKG interpretation section of the cardiology board exam. Here's an EKG book which I have written. You can take a look at that on Amazon.com. But all the chapters in this book have been recorded in video format on my YouTube channel, and you can watch those at your leisure. If you are preparing for cardiology boards, or if you just want to learn about EKG interpretation, the best way is to learn how the experts do it and emulate what they do. And that is, if you learn how to interpret the EKG in a systematic, you can follow my green arrow here. If you follow the interpretation of EKGs in a systematic manner, as it is explained here, that is the way in which the cardiology boards test the cardiology fellows, that is going through the general features, rhythm, conduction disturbances, axis and hypertrophy, clinical disorders, ischemia, infarction, and pacemakers. I have a separate presentation for the overall EKG interpretation chapter, and I have specific videos created for each. My mouse keeps disappearing. I have created a separate video for each one of these sections, and in this presentation we are going to be concentrating on atrioventricular conduction disturbances. In the previous video I talked about ventricular arrhythmias and junctional arrhythmias, and in the next video I'm going to be talking about electrical axis from a board point of view, and also about right and left ventricular hypertrophy. Atrial hypertrophies atrial enlargements were covered in the first segment. So please do watch those other videos. Let us begin with the feature presentation, that is atrioventricular conduction disturbances. And here's an electrocardiogram which shows the rhythm. And whenever we are looking at the rhythm, the first thing we need to determine is what is the underlying rhythm. Is this sinus? If it's sinus, is this sinus rhythm or sinus arrhythmia? Then we look at the various intervals. Is this narrow QRS complex? Is there irregular P wave before each QRS complex? What is the relationship between the P and the QRS complex? What about the T waves? Are there any STT changes, or the T wave inversions and P waves? And the story goes on. And when it comes to conduction disturbances, we are talking about the electrical system of the heart, basically, where there is either a block or a delay or an accessory pathway that can accelerate the propagation of the electrical impulse. So the electrical impulse is determined by the time it takes for it to travel from the sinus node to the atria, and from the atria into the AV node into the ventricles. And again, in the ventricles we have the bundles, which can also either delay or block the propagation of the impulse. So that's why we look at the intervals when it comes to conduction disturbances. Here we look at the PR interval and see if the PR intervals are constant. That relates to atrioventricular conduction disturbances because we are predominantly talking about diseases involving the AV conduction system, which is the AV node, the bundle of His. So those are the two main regions we'll be concerned about. If the PR is greater than 200 milliseconds, it is considered to be first degree AV block. When we are talking about AV block, there's grade 1, first degree, then we have the second degree, which is divided into Mobitz type 1 or Wenckebach, and second one is Mobitz type 2, which is a more serious one. And finally, we have a AB block 2 to 1, which is a sort of a in-bit sandwich between Mobitz type 1 and Mobitz type 2, because we may not be able to say which one it is just looking at the electrocardiogram if all we're given is a small segment of the strip. Then we have, of course, the AB block, third degree AB block, and there's also another condition known as the high-grade AB block, where it may not be complete heart block, but there may be some beats that can get through into the ventricles. And of course, the accessory pathway, which is the Wolff-Parkinson's-White syndrome, which is a congenital disorder, and we will see AB dissociation, which is commonly seen in patients with complete heart block. So let's look at a tracing here. We look at the tracing here, it becomes pretty obvious a few things. Number one, it is a supraventricular rhythm for sure. And of course, this is sinus. If this is lead 2 and the P waves are upright, this is a sinus rhythm. However, sinus origin, but however, when you look at the intervals, that's where the real story begins as far as conduction disturbances are concerned. If you look at the PR interval from the first cycle to the second cycle to the third cycle, you see there is progressive prolongation of the PR interval, which is suggesting that the AB node is getting fatigued with each heartbeat. As a result, it takes longer for the impulse to travel from the atria through the AV node into the ventricles to activate the bundle branches to create the QRS complex. As a result, after 3 cycles, the P wave is dropped. So this is Wenckebach or second degree AV block Mobitz type 1. And there are several features that we need to take into account when we are talking about Mobitz type 1 or Wenckebach, and that is there is a progressive prolongation of the PR intervals. There is progressive shortening of the RR interval. Point number 2. Point number 3, the next P wave fails to conduct into the ventricle. The PP intervals remain constant, and the next beat that comes up has a shorter PR interval compared to the previous PQRS complex, which was seen before the QRS complex was dropped in the next cycle. So there are several points we have to keep in mind, and let me summarize it. There are several points we need to keep in mind. Number 1 is progressive prolongation of the PR intervals. Number 2 is shortening of the RR intervals. Number 3 is dropped QRS complex or failure of the impulse to travel through the AV node to activate the ventricles. And then there is a shorter PR interval after this pause. In addition to that, the RR intervals get shorter. It becomes more apparent if we have longer cycles of Wenckebach. And how do we differentiate this from Mobitz type 2? If this is in a Mobitz type 2, we have a fixed PR interval, and that's why if we have a fixed PR interval and the next P wave is dropped and we have a fixed PR interval following that beat and the next wave is dropped, we cannot be sure if it is Mobitz type 2 or type 1. That's why we have a 2 to 1 block. I may have an example of that. And let's see, here we have another situation here with a wide QRS complex. It could be bundle branch block because each one of them have preceding P waves. And here we see something that is quite dramatic, and that is we have a constant P to P interval here, but we have 2 conducted beats with a bundle branch block. Then we have 2 beats dropped where the impulse failed to conduct through the AV node. And as a result, we have the next 2 beats conducting normally, of course, with a bundle branch block. So this is an example of AB block second degree Mobitz type 2. So this is not a first degree AV block. This is not Mobitz type 1. We don't have a progressive prolongation of the PR intervals. Number 3, the PR intervals are constant in the conducted beats. As a result, these are some of the features which are pretty important in terms of diagnosing Mobitz type 2 AV block. But as I said, if all we have is one normal beat and one block beat, one normal beat, one block beat, we just cannot say. We can always say is AV block with 2-to-1 conduction. And that's an important differentiation we have to make. But somewhere along, if you have a long strip, you may be able to identify if there was a change in the PR interval or if there was any evidence of visible Wenckebach to differentiate it. Now here's an example of a constant PR interval, drop beat, and a PR interval which does not look shorter than the previous beat. You remember I mentioned when I was talking about Mobitz type 1 or Wenckebach, always look for the PR interval before and after the dropping of the QRS complexes. That will be an important clue to determine whether you're dealing with the Mobitz type 1 or Mobitz type 2 AV block. So here we have 2 drop beats. The PR interval here, they are all constant. So that is one point that will help us to identify this as Mobitz type 2, Mobitz type 2 AV block. And here's an example of a complete electrocardiogram, which is a real electrocardiogram. And here, if you look at this PR interval is prolonged, so we have a first degree AV block. Then the PR interval gets longer, and there's the drop QRS complex. Then we get a PR interval here, which if you look at it here, this is supposed to be slightly shorter than this cycle. This is much longer. And these are some of the salient features of Wenckebach, which we need to imprint in our mind, because they are not going to give you a Gordon variety Wenckebach or types 2 AV block. They are going to give you examples which are borderline, and you really have to pay attention to the features I was talking about. The RR intervals are extremely important. If you see progressive shortening of the RR intervals, that is more in favor of a Wenckebach versus type 2, where the PR intervals are constant. The RR intervals of the conducted beats are constant, except that you see dropped QRS complexes either in every other beat or every 2 beats. It's like a sinus tachycardia, more or less, and low voltage in the limb leads. And an interesting thing that we are noticing here is we have QRS complexes which are narrow. So they are most likely supraventricular in origin. So what are we dealing here? Is this a complete heart block where we have atria beating at their own pace, ventricles beating at their own pace, and AV dissociation? And we see from here to here to here, they look constant. So it could be sort of a complete heart block with an escape rhythm, but it is exceedingly slow. It's like 30, less than 30. So this is pretty slow, but this is what we are dealing with. And if we see some of the beats conducted and a different morphology of the P wave, which is called the fusion beat, then we know it is not complete heart block. But if we see that there's no fusion beat, then we are talking about a complete heart block with the escape junctional rhythm here. Okay, here's another example of what looks like atria and the ventricles acting more or less independently, or maybe you could say this could be like a fusion beat, because this morphology of the QRS complex is slightly different from those of the previous beats. First of all, we have a sinus rhythm underlying with the constant P to P intervals. Then we have an independent narrow QRS complex, which appears to be between 40 to 50. So this is an escape junctional rhythm. And here we have an independent P waves along with what looks like maybe one of the beats that was conducted. So this is an example of a high-grade AV block where occasional P waves are conducted with an escape junctional rhythm. And here is a sort of all these images or the various degrees of AV block put together. Here we have Mobitz type 1 with progressive prolongation of the PR intervals with narrowing of the RR intervals as the cycle progresses with a drop to P wave and resuming with a shorter PR interval compared to the last beat that was conducted normally, or I should say partly normally. And Mobitz type 2 is we have a constant PR interval, we have a constant RR intervals, we have a dropped P wave, and the next PR interval is similar to the previous PR interval before the QRS complex was dropped. And this is an example of a 2-to-1 block. You cannot be sure whether this is Mobitz type 1 or type 2 unless you have long strips to see if there is somewhere there is more than one QRS complex that is not conducted. Here is a similar example of what we were talking about. We have the first degree AV block with significantly prolonged PR intervals with a normal RR, with a normal cycle. And here's an example of a Venke block with a drop. This is the second degree Mobitz type 2, which we already talked about. This is like 2-to-1 block. And this is a third degree AV block with junctional escape rhythm. We have independent P waves acting here, which is also pretty slow. And we have independent QRS complexes. To sort of look at it from a theoretical background, we have to look at the PR intervals. If you have a constant PR interval, then you're dealing with first degree AV block or second degree heart block. Let's imprint that pertinent point. When you're talking about AV nodal conduction disturbances, we are talking about conduction of electrical impulse from the atria to the ventricles, because that's what we see on the electrocardiogram, P wave QRS complex. And what is going on behind the scenes is the AV node, and that is reflected in the PR interval. So if the PR intervals are constant, this is what we see, first degree heart block or second degree heart block type 2. Whereas if you have a variable PR interval, you could be dealing with second degree heart block type 1 or third degree heart block. And let's look at some examples of something that's going on here. The first thing is we need to identify what we are dealing with. And here is an example of, first of all, it's a supraventricular rhythm. Is this sinus rhythm? And do we see P waves? Yes, we see P waves. There's also slightly more negative deflection in lead 2, which suggests left axis deviation. But this is not adequate enough to call as left anterior hemiblock, because we need to see more than minus 45 degrees. That means the S waves have to be much more significantly deeper compared to the R waves. So we have left axis deviation, and we also have a negative deflection in 2, 3 and AVF. But if you look at the lateral chest leads, we may have like a RSR prime here. We have a delta wave here. So in the presence of a delta wave, we cannot really say these as representing ischemia, because these may all be related to secondary repolarization abnormalities because of the Wolff-Parkinson-White syndrome or WPW syndrome. So we see the delta wave here, and of course I told you about the left axis deviation, and as I said, these are non-specific T wave changes which may be related to the conduction disturbance. Here again we have, you just look at and see if there's a P wave preceding each QRS complex, which does not appear to be, and if they are they marching simultaneously. So here's a P wave, and here's a P wave, 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 here's a P wave. And the QRS morphology looks very similar and it's narrow. So this is an escape junction rhythm with complete heart block. If we had seen one of the beats being conducted, deforming the QRS morphology in a long rhythm strip, then you can say it's a high-grade AV block. But here it looks like it is an example of a complete heart block because we have independent atrial activity which is not interfering with the escape junctional rhythm. So here we have another example of what looks like the atria are beating here and the ventricles are beating. The atrial rate is faster than the ventricular rate, and the ventricles appear to be sort of a escape junctional rhythm because of narrow QRS complex, and the RR intervals seem to be constant here. And I always look for, when I'm looking at a tracing like this, is there AV dissociation? How do we come to the conclusion there is AV dissociation? If none of the atrial impulses are getting to the ventricles, in which case you will see a fusion beat, then we are looking at complete AV dissociation. That means the atria are beating independently versus the ventricles which are beating independently. So there is no link between those two. And that's what we are seeing here. The atria are beating independently and they are not making a dent on the QRS complex. So we have ventricles beating independently. And this is an example of a complete heart block. So ladies and gentlemen, this is a quick overview of the conduction disturbances, AV conduction disturbances, which primarily refers to the AV node conduction. The main purpose of the AV node is to delay the impulse so the atria can empty the blood into the ventricles and completely fill the ventricles before the ventricles begin to squeeze. And that delay is of great importance in maintaining cardiac function. And that's a magical creation, I should say. And any disturbances in that are reflected in the PR intervals, which we talked about. Thank you so much. And please do watch other videos we have on cardiology seminars. And please do subscribe to our YouTube channel. I will see you in the next presentation.